Well, good morning again. If you didn't catch my name the first time, I'm Frank Markle. I'm the Executive Director of CAHSPR. It's my pleasure to welcome you today to what we think is going to be a very exciting conference on advancing quality through regional clinical governance. I'd like now to introduce Yves Bergevin. Yves, please, welcome.
Bonjour, good morning. It's a real pleasure to be here this morning and to share with you some of the findings of this report, which is entitled Transforming Regions into High-Performing Health Systems. But before I start, I would like to say that it's particularly good to do this in Toronto, a province which focuses so much on quality. And I think what we've tried to do in this report is to address quality at the population level, both in terms of relevance, timeliness, and of course, continuity and quality of care. First, I'd like to acknowledge some people who contributed to this study. First of all, Denis Roy, who had the inspiration to think that we were ready for such a study and to have enabled such a study. So thank you very much, Denis, for this. To Jean-Louis Denis for his continuous creative thinking around some very challenging organizational and systems issues. Thank you very much. And to all the other colleagues, and I'll mention also perhaps Minister Jean Rochon, former Minister Jean Rochon, was very gracious to take a step back and to look at some of the work we had done and to provide guidance. So that was really appreciated. But perhaps the most important thanks were the deputy ministers, assistant deputy ministers, CEOs of regional health authorities or LINs or the like, who gave their time and were agreed to speak frankly, without being quoted, obviously, anonymously, to make this study possible. And then the funders, the Canadian Foundation for Healthcare Improvement, and Stephen Samus is a co-author on this, and thank you very much, Stephen, and the team at the Foundation for this. And then, of course, l'IPCDC is an interesting organization in Quebec which is mandated to help foster new knowledge and the implementation of knowledge into improving health systems. So basically, first of all, to say that the report is available in PDF on the website, I'm told, as of a few minutes ago, and is being translated in French, which will be the French version will be available in the month of April, towards the end of the month, and we will therefore make sure that it's broadly distributed in both English and French. The purpose of this report was to provide insight and, to the extent possible, evidence on the impact of regionalization, what regionalization has had across Canada, towards the triple aim of better health, better care, and better value. And then to try and distill from that the major findings and a way forward, which would provide a vision for regionalization towards high performance and therefore identify areas for improvement. And very much in the context of this conference, towards advancing quality, but quality taken not just at the individual clinical level, as we often think of it, but thinking of it in terms of systemic quality or population-based quality, relevance, timeliness, etc., and value for money. So with a view to contribute in a modest way to transforming regions into high-performing health systems. The methods were fairly straightforward and simple. We did a review of literature, a scoping review, looked at over 250 publications, and we retained 123. And we also did interviews, selected 32 health leaders from across Canada. We didn't want to go beyond that given our time. And 30 out of the 32 accepted to be interviewed. So we had a 94% response rate. We informed them that this would be anonymous, that we would not attribute the findings to any one individual, but that their name would appear as an annex to the report, and their name is at the end of the report. A mix of deputy ministers, assistant and associate deputy ministers, 2 former ministers. We did not want to get a political opinion on this, so we purposefully did not ask current ministers for this. CEOs of RHAs, leaders of Canadian organizations, academics, including a dean, and we guaranteed anonymity of response, and I think that was very important because many of them told us that if anyone ever found out what they had said, they probably would lose their job. And this is testimony to the frankness of the opinions, and we will obviously guarantee that anonymity. And then the research team met on several occasions, and people such as Jean-Louis and Denis commented, and we thought through this process. Now, the strengths of the study: first of all, senior-level health leaders were interviewed from across Canada, all provinces and 2 out of 3 territories. And there was very strong convergence of insights across Canada among the senior leaders and with the literature. And when we sent the report back for comments, we had very strong agreement from 21 out of 26 responders, and then strong agreement with 3 others. So we believe the report reflects their collective views. The limitations were that we could not identify a single robust evaluation of regionalization. So this was, I think, important to note that we're spending billions of dollars in Canada and are not really evaluating our performance very, very well. The other point is that the literature was full of mostly expert opinions and not sufficient data in terms of comparing the performance. Now, before we dive into the report, let's put this in context. Canada continues to produce good health. We have very high life expectancy. We're only 2 years behind Japan, and we have had increase in life expectancy of 3 years over the past 7 years. So we're continuing to produce good health. However, and I think Stephen Lewis needs to be credited for this, as he summarized very well, that Canadian healthcare continues to be an underachiever. And in fact, beware, I think we may risk seeing being overtaken by the US healthcare system if we don't watch it. And this is something we were discussing yesterday evening with Frank and colleagues. There are real changes south of the border that we need to be made aware of. Now, if we compare Canada's performance against only 4 indicators which are very relevant to patients and clients, we see that in Canada, those who spent $2,000 or more out of pocket in the past year was 0% in France, 9% in Canada, and 21% in the US. Could get the same day or next day appointment, 83% in France, 57% in the US, and only 45% in Canada. Access to after-hours care, 69% in France, 55% in the US, and 41% in Canada. And then if we see how weak our primary health care is, what happens is then people end up in the emergency room, probably not always for the right reasons. In France, access to the emergency department use in the past 2 years, 15%. In the US, 39%, and in Canada, 39%. So if a country such as France can decrease that dramatically its recourse to emergency department use, then maybe we need to think long and hard what we are perhaps not doing sufficiently in Canada. Now, please don't try to read this slide. It's in the report, but what it shows is the changes in regional structures in time and across the country. And what we see is there's just two trends, maybe. Regions are getting larger, and we're stabilizing towards a model, and I'll come back to that in a moment. But really, a lot of this has been haphazard and without much evidence before the changes. So we see that change has often been driven politically with insufficient evidence. Having said this, I think we see emerging from that a two-level governance system. And every province and territory, except Ontario, I would call it the control, not the placebo, but every province except Ontario has moved pretty much towards a two-level system, with the provincial ministry providing the funding, the overall governance and direction, and health authorities, regional health authorities in the larger provinces, and obviously health authorities in the smaller provinces, such as PEI, providing the actual delivery. The other finding is that the optimal size of regions. Now, Canada is extremely varied in its geography, and we need to remember that in our analysis. But most people felt that a population, if it was possible within the territory, which is obviously not the case in Nunavut or in PEI, but that a regional size of 350 to 500,000 was probably optimal, with transport times by road of no more than 3 to 4 hours, so as to be able to facilitate patient transfers and also the right kind of supervision by the leaders of the regional health authorities. The other major conclusion of this report, major finding, is related to the triple lane. We think that overall we're probably better than before, but it's been very variable and partial across the country. In terms of better health, we see an enhanced population health approach. There's not much doubt that there's much better regional planning leading to an enhanced population health approach with more service delivery, but also public health and intersectoral action with municipalities. People have really taken on the idea that we need to look after a defined population and not just taking a clientele approach. Better care, I think people have noticed that the regional service delivery plans, as they are being developed, are taking into account the needs of communities, regrouping of services to achieve higher quality, a very important phenomenon, as often services were of insufficient volume to be able to guarantee quality, and also the strengthening of clinical networks, and very happy to see Tom here in the room. And so we think that there has been better care overall across the country through regionalization. Better value? Well, regionalization was done at the time of fiscal constraints, so it's very hard to tease out. However, there is evidence of better value. First of all, the regional service delivery plans are based on relevance with a certain degree of priority setting. Also, the regrouping of services have lowered unit costs, and whilst providing better quality services. So we think that on the whole, there is, in fact, better value through the system. So better health, better care, and better value, but better than before, say better than the 90s, but variable and partial. So very variable across Canada. Citizen engagement. There's been an attempt to take a population health approach and therefore more dialogue with the elected officials, etc. But the dissolution of the local health boards in many of the smaller institutions has meant less citizen engagement. So this gets both pluses and minuses. In terms of engagement of physicians, this is improving, but it's variable, and frankly, it's weak. It's a critical issue. Physicians are not sufficiently engaged in the system. And then a surprise, given the history of Canada, it's not a surprise, but it's still a surprising finding, is the issue of primary health care. We have a long history of general practice. We have superb teaching of family medicine and high-quality clinicians. But the performance of our primary health care is very variable across the country, with Ontario, I think, doing an extremely good job, perhaps still to be improved, but a good job, and other provinces, not to mention my own, of course, not doing so well. So we have this issue, tremendous variability across Canada, but also weak relative to other countries. So I think if we were to give a grade to this, we wouldn't give much more than a C. Perhaps other provinces might get a B, but it's not, we have a lot of work to do there. Now, the other major finding is there has been slow and variable progress on information systems. We do not have universal electronic health records, and these records are not interoperable with the information systems. So we're really not, we couldn't fly, if this were an aircraft, we wouldn't be flying on instruments. It would be very dangerous. The other thing is that there has been frequent reorganization of the healthcare delivery architecture and of regional structures, so it's made it very difficult to assess how the process has gone. And there has been insufficient clarity of roles between the provincial government and the regional health authorities. And there has been inadequate financial coverage of drugs, which has meant, of essential drugs, which has meant that, especially in the ambulatory setting, that often people have had to have recourse to hospitals just for the payment of drugs, which is frankly not a good use of services and incurring extra costs. So we see regions as integrators towards health improvement. I won't go into detail, but you can have a good read of the report if you're interested. We think that regions can play a role as integrators towards higher performance. And in looking at the role of the regional health authority, we think that it's placed ideally to try and get citizen engagement, physician engagement, and engagement of the management of the regional health authority to try and deliver better care and better health. We have come up in the report with a vision. The vision reflects not only recent developments in high-performing health systems around the world, including the accountable care organizations in the US, such as Kaiser Permanente and Intermountain, but what is very important is that if we were to combine the best characteristics of each health region across Canada, we would end up with a fairly high-performing system. And we were surprised by the lack of interprovincial discussions of what works and what doesn't work. And I think if we were to combine the best that we find across Canada, we would have a fantastic, well-performing health systems across the provinces. We therefore believe that, given that it exists in parts across the country, that such a vision is realistic in the near term for the provinces and the territories. Now, we've identified 7 areas for improvement. I'll go through these over the next slides. And the first one is to manage an integrated regional health system as a results-driven health program. One would never think of spending billions without having a good functional measurement system with clear goals, targets, milestones, baselines, and then to monitor the progress towards achieving those goals. Yet, it's very difficult to see such a system in place in any regions. In all fairness, regions have strategic plans, service delivery plans. It does exist in parts in different places, but we don't have a clear system of accountability to the Canadian people across the country. There's also the issue of role clarity, and I'll come back to that in a moment. So we're really failing our accountability, in a way, to the Canadian people. And we do not have real-time information systems. So we're not able to adapt the system in real time. Now, the second area for improvement is really to not forget wellness promotion, public health, intersectoral action for health. We sometimes tend to do that. We've done much better with tobacco, with bicycle paths, etc., but we still have a long ways to go. And these are lower-lying fruits. They can be revenue-generating, such as tobacco taxes, and we should really redouble our efforts for wellness promotion, especially in the context of this demographic transition, of healthy aging, and those who unfortunately have a lot of burden. So we need a whole-of-government approach to health and wellness, and we need much enhanced public health and intersectoral action for health with the municipal governments and other elected officials. The third one is really primary health care. We need to do much better in terms of strengthening primary health care across the country using team approaches for continuity and integration of care with good appointment systems in real time, focusing on maintaining autonomy with patients, keeping them at home and in the community, and focusing on high quality, effectiveness, and efficiency. And so we need to think through the relevant performance-based contracting, and I use these words carefully, to foster such attributes. So we really need to think through our contracting with family health teams, etc., if we want a high-performing system. The fourth one is to involve physicians in clinical governance and leadership, partner with them in accountability for individual care and for system performance, and then learning from accountable care organizations where physicians, by the way, are happy, and I think that's very important, that different ways of working the system can also lead to tremendous professional satisfaction, to foster greater engagement and leadership of physicians in clinical governance and clinical networks, including on accountability issues, and to address the required changes in physician remuneration, and I hope we discuss that today, to try to ensure that budget envelopes be provided to regional health authorities for physician payment. And we think that this is important in the context of regional service delivery plan, both for hospital care, but most importantly, probably, for primary health care. The next one is to further engage citizens, and I think we need to do much better in engaging citizens in shaping their own destiny, meaning their wellness, but also in shaping their health system. The sixth one is to strengthen our health information systems and make them interoperable with electronic health records, universal electronic health records. This is not the case, and some provinces are way behind others on this matter. And frankly, if you compare that to the mobile apps that every patient has at Intermountain and how those feed into their electronic health records and how that feeds into the health information system in real time, you say, are we on the same planet? The last one, but not the least, is obviously to foster a culture of excellence, learning, innovation, and research, and to really encourage this adaptive capacity towards continuous quality improvement. The other one is the distribution of roles. Provinces have devolved to regional health authorities without doing their business process re-engineering within the ministries. So you have officers in ministries who want to micromanage because they still have a job and they still have to account for that job. So you have an issue of micromanagement by ministries, not because the officers are not good. Having worked in the Ministry of Health of Quebec, I can fully appreciate that, but really there's a need for role clarity and accountability across this role clarity. With provincial governments taking a population policy framework, whole-of-government approach to health, financing, provincial public health and tertiary care, perhaps through academic health authorities or other such system, but then the regional health authorities being responsible for the delivery, both especially of primary health care, to strengthen secondary care, to contract out for tertiary care, and to really make sure that they work with the regions and the municipalities in other sectors to try to promote health and wellness. So in these 7 areas of the way forward, the first one is, I would focus on 2, and this is very relevant to Ontario and to the discussion today. The first one is on primary health care. We should and could do much, much better in improving primary health care to decrease the pressure on our health system, and many countries, and the evidence is clear in the literature, that we can save costs in the long run, but more importantly, really improve the quality of life and probably the health status of populations to enhance primary health care. And the second one is to engage physicians in clinical governance and leadership and partner with them in accountability, including in looking at the challenging issue of physician remuneration. So in conclusion, we think that Canadians are demanding better performing health systems, and we now have increasing evidence of what works. So given the need to be accountable to our Canadian citizens and colleagues, and the fact that we have evidence, then we must act to try and improve the system. The way forward, the 7 areas of improvement could have a profound impact on the health systems across Canada, and they would have a modest one-time cost and long-term recurrent cost savings. So we're not proposing anything that would have major financial impact on the system. On the contrary, we think that this can lead to cost savings in the long term. And very importantly, if one were to combine the best characteristics of health regions across Canada, one could rapidly move towards a high-performing health system and provide better health, better care, and better value for Canadians. Thank you very much.
Thank you, Yves. I'll now ask Greg Marchaldon to speak as a discussant to Yves' paper. Greg?
Okay, I was asked to basically provide a commentary in terms of the situation in the rest of Canada and Ontario from a governance perspective and the perspective of comparative regionalization. And first of all, I want to thank Yves and everybody that worked on the report for conducting the first major overview on regionalization that's been conducted in many years. Given the importance of regionalization to decision makers, it is really quite surprising and actually very sad that so little attention has been paid to regionalization. And here I, in a sense, hold my own constituency, academics, partly responsible for this. It really is surprising because there are so many natural experiments that have been going on in the country for the last 20 years that it would have been extremely useful for all decision makers to understand, based upon study and evaluation, the differences. So, as Yves pointed out, in terms of impact, there has really not been one single robust evaluation of regionalization in this country. I would take it one step further, and I would argue that, in fact, there's a crisis of regionalization in Canada today. There is a huge division between the political and the administrative tiers of government. What Yves presented was mainly the administrative consensus on the issue, but at the political level, there is great impatience with regionalization, a desire to achieve change more quickly, and a loss of confidence to some extent in regionalization. And the conflict between these two tiers, I think, is growing deeper. It is not lessening. So I think that is the context that we're dealing with here. And when it comes to frankness of opinion, I very much respect the opinions that were provided in the survey that Yves and his colleagues did. But it's all very Canadian in the sense that the edges are rubbed off. And although people state what they certainly felt were their views, they moderated their views, even in terms of the interview. And I think it's time for some much more direct and hard-hitting discussion about this. I'm only going to focus on the two connected recommendations that Eve pointed out, number 3 and number 4, and they are connected. The number 3, ensuring timely access to personalized primary health care and proximate services, and 4, involve physicians in clinical governance and leadership and partner with them in required changes in physician contracting and remuneration. So the question remains, how do we actually accomplish this? We've been trying, that was the purpose of regionalization in many respects. We've been trying for years and we haven't accomplished it. So how do we accomplish it now? The first thing is when it comes to primary care, regionalization largely failed because primary care wasn't part of regionalization. And it wasn't part of regionalization for a very simple reason. Provincial ministries in all their forms kept medical services within the ministry. And that meant basically remuneration and contracting. And they did so for a host of reasons, probably the most important of which is that every provincial medical association was very much against the idea of this part of the health portfolio being regionalized. And that is not an issue that we've really dealt with in this country very directly. So we're stuck. No one is prepared to move in any of the regionalized provinces at this point. That's fairly clear. So let me end on Ontario. Well, in Ontario, you kind of have half regionalization. Some would call it regionalization light. The Patients First document that came out in December, when you read it, there are two thoughts that came to my mind. Is this about catching up to the other regionalized provinces? Or is there a possibility that it might imply leapfrogging? And when I think about that, I think about the fact that naturally white papers of this sort are going to present policies in somewhat vague ways because there's a fair amount of consultation that needs to be completed. But there's only one way, I think, that the government of Ontario could leapfrog other provinces and actually put itself in a better position and not put itself in the same position that the other province is in. And that is to transfer the medical budgets to the LHINs and actually require the LHINs to take the accountability for physician contracting and remuneration. This is a very difficult thing, of course. It's also foreshadowed in the document in a couple of places that the Ontario government may not do that. There are other ways to achieve this purpose, but none would be as direct, and none would go to the heart of the accountability issue as quickly. So that's why I suggest it, mainly to get the discussion going. Thank you.
Thank you, Greg.